good morning or good afternoon, whichever the case may be. I would like to thank Aphrodite again for the opportunity to be a part of this wonderful conference. I certainly hope that we have the chance to convene again in person and that I'm able to be a part of this wonderful experience, wonderful group of people. It's a pleasure to be here. Today I'm going to talk to you about transcatheter pulmonary valve interventions after bacterial endocarditis. I like to think about this issue in terms of two primary scenarios. The first of those is a first-time transcatheter pulmonary valve replacement after prior endocarditis, either in the acute phase or remotely after a prior endocarditis episode. And then the second scenario is transcatheter intervention after endocarditis of a previously implanted transcatheter valve. And that can either be acute, again, as a temporizing therapy to a more definitive surgical therapy, or with the intention of a longer-term benefit in and of itself without temporizing. And then this can also be an issue remotely after an endocarditis of a transcatheter pulmonary valve. Before getting into the specifics of the transcatheter pulmonary valve replacement risk and scenario, I think it's absolutely critical to establish the background that we're working with in this patient population, namely patients with complex, usually conotruncal heart disease, most of whom who've had repair with prosthetic material and usually with valve-containing prosthetic material. These patients are far and away at the highest risk for endocarditis, regardless of transcatheter pulmonary valve therapy, regardless of any other therapeutic setting. So when we talk about this issue, when we consider this issue in this patient population, endocarditis comes with the territory. It's just part and parcel of this disease process of this population. So that has to be part of the foundation. Moreover, I think, as we all know, a history of endocarditis is also an incredibly strong risk factor for subsequent endocarditis. So we are talking now about a population of patients who are at extreme risk for endocarditis relative to other patients with congenital heart disease. Again, this is not a function of the therapy per se, but of the population that we're dealing with. So every discussion around this issue needs to be working from that same background understanding of the high baseline risk of endocarditis. And this has also been sort of established in surgical databases. In this study from the Society of Thoracic Surgeons, a full 12% of patients who underwent surgical pulmonary valve replacement had a prior history of endocarditis, for example. Now, with respect to transcatheter pulmonary valve therapy, the occurrence of endocarditis has been recognized from very early on in the collective experience. This outcome was first reported by Bonhoeffer's group in the 2005 paper, in which they reported one patient with few details. And then in their follow-up report in 2008, they reported a total of 5 cases out of 155 implants with further details. And not surprisingly, most of those patients had known predisposing factors, including prior history of endocarditis. Now, since those early reports, there's been an extensive literature that's developed around this topic, and I won't cover that in detail here, primarily because I don't have enough time, but also because it's all pretty consistent. And I think what our understanding of this issue is at present is that about 2 to 4% of patients per year will develop endocarditis or a bloodstream infection. So the incidence rate is anywhere from 2 to 3.1% per patient year for endocarditis. There have not been many studies that have had enough statistical power to establish risk factors, but we're getting there. In this study, which combined all of the prospective series of the Melody valve, age less than 12 years at the time of implant, and a peak gradient greater than 15 millimeters mercury after the valve was implanted, were associated with significantly higher risk of endocarditis. Now, in a literature review prior to that, of all the reported cases, unique cases of endocarditis after a transcatheter pulmonary valve replacement, it was not possible to do statistical analysis of risk factors because all of the baseline denominator data were not available. But the fact that 14% of those cases had a known prior history of endocarditis was suggestive that that could be an important risk factor for endocarditis after a transcatheter pulmonary valve. And indeed, subsequent studies have supported that, risk factor. In this study from UCLA, single center, a prior history of endocarditis was the strongest risk factor for subsequent endocarditis after either surgical or transcatheter pulmonary valve replacement. And then in a study that is, I can't get into too much detail because it's still in revision at JACC, but a series, multi-center series of about 2,500 patients with over 8,500 patient years of follow-up and 182 cases of endocarditis. The three risk factors for endocarditis on a multivariable analysis were prior history of endocarditis, younger age at transcatheter pulmonary valve replacement, and a higher post-valve replacement gradient. So again, pretty strong consistency over our evolving experience establishing these as important risk factors for endocarditis. So knowing that prior endocarditis is a risk factor for subsequent endocarditis after a transcatheter pulmonary valve, how should we approach these patients? Now, I don't think it makes sense to simply say we shouldn't do transcatheter pulmonary valve replacement in them because, as we've already shown, this is also a risk factor for subsequent endocarditis after surgical pulmonary valve replacement. So the answer is not to say don't do a transcatheter valve. It's more complicated than that. I think we need to look at patients on an individual basis, figure out whether, for example, there are other potential endocarditis risk factors. Is there a stenotic, difficult to open up conduit, homograft conduit? Does the patient have a DeGeorge syndrome or other reason for immunosuppression? Is it a younger patient? Is there poor dentition, etc.? And in the context of this full picture, we can undertake diligent counseling, inform the family, and then if indeed we replace the valve using a transcatheter device, really make sure to provide thorough, repeated information about the signs of endocarditis, the need for rapid evaluation, really stay on top of the patient and make sure that if it does occur, which it very well might, that it is recognized as soon as possible, treated as soon as possible, and hopefully the complexity of that can be mitigated. Now, we would recommend in all patients that prophylactic antibiotics and antiplatelet therapy maintain. These are not proven to be beneficial in this population, but it stands to reason that they will be helpful. We have really very little to no data on the issue of maintenance suppressive antibiotics, but that is another thing that can be considered in these patients. But again, I think there's no evidence that surgery is a lower risk alternative compared to transcatheter pulmonary valve replacement. So I don't think we can say that prior endocarditis is a contraindication to transcatheter pulmonary valve replacement. Now, moving on to the second scenario, once a patient with a transcatheter valve develops endocarditis, what do we do? Now, about half of patients in that previously mentioned review were treated medically without invasive therapy. And of those who had invasive therapy, about 25% had a transcatheter intervention first. 6 had simple balloon angioplasty or bare metal stenting, and 4 had a valve-in-valve replacement. Now, of those, a subset were temporizing therapy. In the more recent article that I mentioned in JACC, the series that included all of the prospective Melody valve trials, of 46 patients who developed endocarditis, you can see here 9 had a transcatheter intervention, and of those, 4 subsequently went on to a transcatheter valve explant, so surgical therapy. So that in those cases, the catheter intervention was a temporizing therapy to stabilize the patient and allow for a surgical replacement after further medical therapy and in a more stable hemodynamic setting. But the others were actually a longer lasting and not necessarily definitive, but a longer term therapy and not simply temporizing. So transcatheter intervention for endocarditis acutely is a viable therapy, not only to temporize, but also as a longer-term therapy if there is valve dysfunction. And we've also found that to be the case in the registry study that I mentioned. Of the 182 cases of endocarditis, about half underwent an acute or subacute reintervention for endocarditis. 15 of those, 96, so again, about 17%, were transcatheter interventions. 7 balloon angioplasty, 4 bare metal stents, and 4 valve-in-valve. And of those, about 35% were temporizing. So they were just to get the patient to a more stable place to allow a surgical valve replacement. All of this information taken together, again, shows that about 30 to 40% of transcatheter interventions for endocarditis are temporizing, aimed simply at stabilizing hemodynamics while the patient is continued to be treated medically and eventually receiving a surgical valve replacement. In these cases, the interventions are usually successful. They stabilize the patient and allow for continued medical therapy until the patient has the valve replaced. There's not a lot of follow-up available for interventions that were intended to be longer lasting, but I can tell you that patients who are alive without subsequent reintervention for at least 5 years have been reported, as have cases in which the endocarditis was recurrent and went on to require surgical valve replacement. So I think the jury is still out on those, but in some cases, for sure, it is a viable, if not definitive, therapy. Now, anecdotally, some implanters are using suppressive maintenance antibiotics in these patients, although there's really no data about the effectiveness of that approach. I'm not going to go into detail, but we have developed an algorithm suggesting how to manage endocarditis according to the clinical circumstances of the time, and transcatheter intervention does show up both in patients who are more stable and patients with severe hemodynamic derangements, either as temporizing therapy or potentially as a more definitive therapy if there's no indication to go to surgery. I think one of the interesting findings in the registry that I mentioned a moment ago is that there were 9 other patients, in addition to those 15 who had a transcatheter intervention acutely, 9 other patients underwent a remote transcatheter intervention after endocarditis of a transcatheter valve. But it was not directly to treat endocarditis-related obstruction. It was several years later when the patient developed obstruction or regurgitation or whatever. And all of those patients were alive without explant at the most recent follow-up. So they seem to do actually quite well simply with another valve-in-valve, for example. So in summary, we know, and it's important to keep in mind, that transcatheter pulmonary valve replacement candidates are among the highest risk populations for endocarditis. There is, of course, an important incidence of endocarditis after transcatheter pulmonary valve replacement, and it is higher, definitely higher in patients with a prior endocarditis history. However, this risk is not specific to transcatheter pulmonary valve replacement and should be taken into consideration, but should not preclude transcatheter pulmonary valve therapy. It's important to educate the patient and the family in the signs of endocarditis and the need for prompt evaluation, particularly when they have a prior history and are at higher risk. And it's possible that suppressive antibiotic therapy may be considered and may be a useful option, but there really aren't any data at this point. About half of all reported cases of endocarditis following a transcatheter pulmonary valve implant were treated successfully with antibiotics alone. Transcatheter intervention can be used to temporize effectively in patients with severe RVOT obstruction related to endocarditis. And in a subset of patients with valve dysfunction after endocarditis, a valve-in-valve transcatheter pulmonary valve can be used as longer-term therapy. Now, this approach seems as though it might be better if it's performed remotely after endocarditis, if that is an option. But again, few patients and limited follow-up, but somewhat promising early results. In patients who are treated for endocarditis with medical or transcatheter therapy, a suppressive antibiotic regimen may be considered, but again, is unproven. I really appreciate the opportunity to speak with you about this subject, and I look forward to learning more and potentially updating you in several years' time. Thank you very much.
Well, that was a really very important talk and very concise. Doff is always an excellent speaker.